Hello, everybody. So welcome to LGBT 101, The Medical Perspective. I am Rose Lavelle, and I will introduce myself more thoroughly soon. Um, so welcome. What is this all about? I'm working with Epicenter to provide a monthly video series on LGBTQ health. What better way to really start celebrating LGBT History Month? The real goal of this is to try to get a lot of more education, a lot more knowledge, and a lot more better ability for us to self-advocate and just spread the knowledge. Focusing mostly on all of us in Monterey County, but also in Santa Cruz County and in San Benito County. So first, introductions and explanations also of who we are and what services we all provide. Let's start off with Epicenter.
Hello. Hi, Rose. Sorry. Hi, everybody. My name is Jacob Agamau. I am the LGBTQ plus services coordinator at the Epicenter. The Epicenter is a drop-in resource center for youth, specifically transition age youth, age 16 to 24. And we exist to empower youth by connecting them to community resources and provide opportunities for equity and hope here in Monterey County. We have several different programs under the Epicenter umbrella, including Argente, which is my program, my LGBTQ plus services program. CYC and Youth Council are foster services programs for foster youth. And Friday Night Live is a national, or it's maybe statewide, alcohol and drug abuse prevention sort of advocacy group. We also offer resources for housing, food, jobs, and education, all for our youth in Monterey County. And that's pretty much it. I'm going to ask Haley to join us.
Hi, everyone. I'm Haley. I work at the Epicenter as a media content creator. I do video editing, graphic design, and social media. I work with all the departments. I'm excited to be working with Argente and QTHealth today to bring everyone useful and liberating information.
I was muted. Hi, everyone. My name is Angelica or Angel Dolores. My pronouns are they, them, and in Spanish, I use ella. I'm so grateful to be working with our community to share resources that I'm definitely learning as I go. There's so much out there. And yeah, we're going through some really uncertain times, but our possibilities of collaboration are infinite. So I'm really excited to be starting something like this. Thank you to the Epicenter, to Dr. Rose Lavelle, and to all of you joining us today.
And I'm Dr. Rose Lavelle. So I'm originally from California. I actually have lived in Santa Cruz County basically since 1999, 2000 kind of territory. Spent some time at Cabrillo College, graduated from San Jose State, left the state for 4 years to earn my medical degree at the Netter School of Medicine off in the tiny little state of Connecticut. I'm currently what's called a third-year resident physician in family medicine at the Natividad Family Medicine Residency Program, and I'll explain what a resident physician is here in a minute. I'm also a member of the Gay and Lesbian Medical Association, the World Professional Association for Transgender Health, and probably many other organizations I've half forgotten I'm a member of. But I've been doing LGBT-oriented care for actually longer than I've been a physician or a medical student. It started off, I was supremely lucky and blessed to work with Dr. Jennifer Hastings at Planned Parenthood Santa Cruz for a number of years when I was a wee little pre-medical student. And Dr. Hastings is really the one who taught me the bulk of transgender medicine. And then the LGBT components I kind of picked up along the way. So I really owe it to Dr. Hastings that I'm able to try to help our local community. A resident physician is someone who has completed medical school. They are a physician. They have an MD or a DO degree, and they are finishing their training under the supervision of wiser, more experienced doctors who can sit there on their porch and shake their cane at us and tell us to go fix those medication orders. For family medicine, it's a 3-year residency program, meaning I'm in my last year. And once I graduate from the program, I plan to still practice within the Monterey County, Santa Cruz area. As part of our training as family medicine doctors, we practice in both a clinic and a hospital setting. So my clinic is at Laurel Family Practice, which is part of the Monterey County Health Department set of clinics. We do family medicine. Family medicine is basically primary care for everyone. So when you think back to that old, general doctor who would go house to house and would deliver babies and would do like just everything because there were no specialists, that's us. We take care of kids. We take care of everything from, less than a minute old, all the way through helping people die with dignity and peace. We help take care of people who are pregnant. We help take care of people who are not pregnant. We do all the primary care stuff. Within our clinic specifically, we also do some procedures while we're there. We do skin tag removals. We can put in IUDs and put in Nexpanons, joint injections, all kinds of stuff. Just ask if we can do it. We may be able to. We also do LGBT care at Laurel Family Practice, and actually most LGBT care is within the scope of family medicine. Some of the specific things we do offer pre-exposure prophylaxis for HIV prevention, so that's Truvada or Descovy. We do offer testing and treatment for sexually transmitted infections. We do hormone therapy. I'm probably the one with the most hands-on experience, but everybody at the clinic has been trained to do it. We will provide letters and referrals for gender-affirming surgeries as well. And if you have questions, by the way, toss questions in the chat. We'll answer them once we sort of go through our little presentation. So that's Laurel Family Practice. LFPC sits on the same campus as Natividad, which is our local safety net hospital. 172 beds. By safety net hospital, I mean that we see everyone regardless of ability to pay. So we see a lot of underinsured, uninsured, Medi-Cal, Medicare patients. We're not the fancy place with the koi pond. We're doing a lot of the really hard work with people who can't pay as much. We are also a teaching hospital. That means you see not only residents, but you see medical students. So you see a whole team of doctors when you come to Natividad for almost anything. We are also, I believe we are the only trauma center, certainly in Monterey County, but really along the Central Coast. The next one that I know of, at least going north, is Santa Clara Valley Medical Center. Level 2 trauma center, basically it is almost top tier. The only thing that we don't have is research, but otherwise we take care of trauma services at our hospital. We have the top tier NICU, which is a level 3 NICU. We are a baby friendly hospital. We are also a hospital that does a lot of high risk obstetrical care for people who are pregnant. So we will allow patients to trial labor after they've previously had a cesarean section, so to attempt a vaginal delivery if that's their decision. And really, if I was ever going to be pregnant, I would want to deliver at Natividad. I love our OB care. We also are proud to have the acute rehabilitation unit for those patients who need to rehab. We have neurosurgery, bariatric surgery, colorectal surgery. We have a whole bunch of different specialties. We're also the home of the Diorigo Specialty Clinic, which provides a lot of specialist care for patients in our area. We are proud to be the originators of an Indigenous Interpretation Services program. So for patients who speak Mixteco or Triqui or Zapotec or probably other languages that I just haven't had the pleasure of working with patients who speak, we can provide interpreters on site or via telephone. And we also are proud to have the NIDO clinic, which is our infectious disease clinic, which is where most of the HIV primary care and treatment for things like valley fever happen in our local area. So that's a little bit of us, a little bit of a sense of, so that's Laurel Family Practice, that's me, that's Natividad, that's Epicenter. today's lecture is really just a simple LGBTQ 101. We got to start somewhere. Future lectures will be more specific, and please send us comments, send us chats on or emails or direct messages of things that you want to hear about, because I want this to be useful for people. But let's get into just some 101 stuff. Disclaimer before I start, I have no financial ties to any specific medical treatment that I ever discuss. I don't take money from pharma. The views that I express are my own. They do not reflect the hospital. They do not reflect my clinic. They do not reflect my residency program. They're just mine. And yes, I'm doing an LGBTQ 101. Everyone's terminology is going to be a little bit different, because wherever you are in the world, whatever generation you have been raised in, the terms that you use and the way that you think about all of this is going to be a little bit different. So this is skewed a little bit to my perspective, both as somebody who's sort of, on the younger side, and someone who's been medically trained. So, is it LGBT? Is it LGBTQ? Is there a plus? Is there not a plus? Is it quilt bag? I don't know anymore. So I actually prefer kind of throwing a lot of this out, and I'll kind of show you a little bit of the way that I think about LGBT, and in a broader context. I think what's happened over time is people keep adding letters to include more communities, but then it turns into this big alphabet soup. And there's a different way that we can do that. But just for clarity's sake, LGBTQ means lesbian, gay, bisexual, transgender, and queer. It is, as I see most people use it, intended to be inclusive of many other communities, but as we see, we keep adding letters on. So the way that I actually think about it is gender and sexual minorities as a much broader term. So let me introduce that thought, and we can all kind of think about it and chew on it and talk about it. So a person who is a gender and sexual minority is someone who differs from the dominant culture with respect to their sexuality or their gender or sex. So it includes LGBT. It's actually far broader than that. Sexuality explicitly includes sexual orientation, so who we like, sexual relationships, who we do it with or don't do it with, sexual behavior, what specifically we do. And then gender and sex, gender identity is who we are inside. Biological sex is what our bits are, and the interface between the two. So LGBT or LGBTQ is represented with the ones that I've put in red. So for visually impaired, that would be sexual orientation, gender identity, biological sex, and the interface between gender identity and biological sex. Why don't I use the word queer? Some people use queer as an all-encompassing everybody who isn't cisgender heterosexual. I tend not to use it as much, mostly because it is a reclaimed term and it is not comfortable for many of our elders. It very much in some communities has a strong negative connotation. It means bad things for many people who are within our community. So I tend not to use it, but I do recognize that it is a reclaimed term and it is a preferred term for some people. So it's included here. So let's get into some nitty-gritties. Sexual orientation is who a person is attracted to based on that person's gender or sex. I want to emphasize sexual orientation is essentially biological. It cannot be changed by forces from outside the person. Some people's sexual orientation naturally wavers over time, but efforts to change someone's sexual orientation is called conversion therapy or reparative therapy. It's actually illegal to try to do that to minors in the state of California. So some sexual orientation, so you have, everybody knows about heterosexuality, people who are attracted to a different gender or sex. We have our gay and lesbian folk who are attracted to the same gender or sex, bisexuals and pansexuals who are attracted to more than one gender or sex, demisexual people who are attracted, so I have heard from the community, only once a close relationship is formed, and folks who are asexual or aromantic, meaning they're not sexually or romantically attracted to people, to other people. For just a little bit of fun flavor on the slide, that rainbow flag there's a rainbow flag here that's got pink and teal in it. That's the original rainbow flag. It originally had those colors when Gilbert Baker made it in 1978, I think it was. The colors were later removed, pink specifically, because nobody made enough of that color, to make the more common rainbow flag that we have today. Next to it is the bisexual flag. Next to that is the pansexual flag, and then the asexual flag as well. Many other flags exist. If you want to have a fun time, go looking on Wikipedia. Shifting from sexual orientation to gender and sex, which tends to trip people up a little bit more. I know that most of our LGBTQ community is pretty good with this stuff, but let's just set some ground concepts. So gender and sex. I split this up into sex, gender identity, and gender role, where sex is the biological, it's your hormones and anatomy and physiology, and it's this whole conglomeration of all of those factors that makes you look male or look female, right? I'm doing air quotes. And that's partially changeable. I can change someone's hormones. Someone can have surgery and change their anatomy, but we can't change chromosomes and stuff. So that's sex. Gender identity is very likely to be biological. There were some fabulous studies from the late 1990s where they looked at brains and they figured out that there was a part of the brain that was related to gender identity, not hormone status, not sexual orientation, but really gender identity. It's the internal sense of being a man or a woman or agender and on. And it absolutely cannot be changed by external forces, just like sexual orientation. And then gender role is completely social. When people say that gender is a social construct, they mean gender role. So that's the girls wear dresses, boys don't rule. That's the girls wear makeup, boys don't. Boys go do football and are very strong and muscular, and they're the ones who shoot. And the girls sit home and knit. That is all cultural. And that can be very easily changed on an individual level. If I wanted, I could pass. I choose to wear makeup. I don't have to choose to do that. So sex, biological sex, like I mentioned, it's this what's called a phenotype, meaning it's the appearance of a whole bunch of biological stuff. Some schools will teach that, if you're XX, you're a girl, and if you're XY, you're a boy. And that's really just a tip of a very complicated iceberg. I'll show you how complicated it can be. In fact, let me just flip to that slide. Sex is complicated. This is a wonderful diagram from Scientific American, which I've gleefully used for this presentation. Going from top to bottom, we have chromosomes all the way down to the appearance of breasts or facial hair. Going from left, we have a typical biological female, so what they taught you in biology class, and a typical biological male, that is what they taught you in biology class. And then everything in the middle is what we call an intersex or difference of sexual development. So anything from Turner syndrome, which is chromosomal, to androgen insensitivity syndrome, which has to do with hormone balance. If folks want to get into this really interesting topic and broaden your understanding of sex, I'm more than happy to do that presentation. Let us know you're interested, but I definitely can't cover it in 2 seconds. Then there's this term sex assigned at birth. It's a medical legal designation. It's really based on the external genitals. So when I deliver a baby, I don't pick the baby up, but I look and I say, okay, there's a penis, this is a male baby, or I look and I say, this is a vulva, this is a female baby. And that's what goes on the birth certificate. It's not based on genetics. It's not based on hormones. We don't do any of that testing unless the genitals look what's called ambiguous. It's just a medical legal designation, but we are using that term more and more to refer to someone's the old way we used to talk about it was like their biological sex. So gender identity, in contrast, it's this internal sense of what gender you are, whether you are a man, a woman, neutroy or agender, whether you're two-spirit. That's a term that the Native American communities have been using to reclaim some of their culture before us white people came along and did terrible damage. Gender identity is solidified, bare minimum, it's solidified at age 3. I actually was just listening to a medical presentation. It may be solidified in the womb, actually. Again, it can't be altered by external forces. Gender identity is not a social construct. As I mentioned with sexual orientation, gender identity, any attempts to change one's gender identity, conversion therapy, worsens depression, makes suicide attempts much more likely. It is illegal to try to do that on minors in the state of California. And I will point to David's case, David Reimer. I'm probably mispronouncing his last name. I don't have time to talk about his particular case today, but you can Google his name. And yeah, they tried to change it and it didn't work. And then we have when sex and gender really don't line up. So this is where being trans or being cis comes in. The terms trans and cis actually come from chemistry, referring to, and I'm showing with my hands here, on the same side of or on the opposite side of, so whether molecules are pointing in the same direction or not. So a trans person or transgender person is someone whose gender identity does not match the sex that they were assigned at birth. Doesn't matter what the sex assigned at birth was, doesn't matter what their identity is, they just don't line up. Whereas a cisgender person, they do line up. They are the same. So someone picked me up when I was a baby and said, "Oh, it's a girl," and I happen to agree with them that I'm a girl, but that didn't necessarily have to be like that. So for transgender, also trans with an asterisk, or transsexual, I explicitly bring that term up. It is an old term. It is a term that many people are not comfortable with, but there are still people who prefer to use that term. So it is an old term. You will see it if you're a nerd like me and go digging in the medical literature. It's still there, and some people still prefer it. So when the gender identity is not the same as the sex assigned at birth, you can get something that's called gender dysphoria, which is this intensely distressing, it's this intense psychological distress. Granted, more intense for some people, less intense for others. The only way that we medically have to treat that dysphoria is transition. Transition is a legal, social, and medical process which allows someone to change their sex and their gender role to better match their gender identity. So legal transition, you change your legal name, you change your gender mark, or you change your birth certificate and your passport and all that stuff. Medical transition is where I come in most of the time, which is hormones and surgery to change the body. And often the use of hormones helps relieve some of the gender dysphoria psychologically, even before physical changes start happening. And then there's social transition, which is changing name and pronoun, changing your clothing, changing your voice, to pass, basically, to fit the gender role that in the society that you're living in. Not everybody needs all 3 parts, but they are all, for those who need it, for those whose dysphoria demands it, they are like medically necessary. It's the only thing we have to treat dysphoria. I love this slide that I stole off the internet. So for those who are unable to see it, it's a butterfly hanging on a chrysalis with rainbow-colored wings. And this slide says, "I did not change, I did not transition, I just adjusted my body so that you could see me as who I always was." And, you know, I've taught LGBT health before for psychology students, for medical students, for resident physicians. And one of the points that I always try to drive home is, like, when you transition, you're not changing who you are. You inside are still the same. It's everything on the outside that you change. So that butterfly was always a butterfly. Last bit of terminology, I think. So a trans woman is someone who identifies as a woman or on the feminine spectrum. Typically was assigned male at birth, not necessarily, but often. And a trans man identifies as a man or on the masculine side of the spectrum and was assigned female at birth often. And then I have the trans flag here on this slide too, which is your blue and your pink and your white. How does all this affect health, and why as a doctor do I care? So I think about gender and sexual minority health under something that I learned when I was a psychology student back at San Jose State, and that's the concept of minority stress. All minorities have a higher level of stress. All minorities. The more different minority communities you belong to, the higher the level of stress. And the more stressed that you are, the stress alone results in higher rates of depression and anxiety, which lead to more substance use, which leads to more cancer and more infections. All of this leads to less physical activity, so more obesity, leading to more diabetes and high blood pressure and dementia and heart attacks and strokes. And I could go on and on and on. Plus, as a community, gender and sexual minorities are discriminated against. So then add on the layer of all the violence that we all know is happening. We're well over 30 trans people who have been murdered this year, mostly trans women of color. I heard a statistic recently that 1 in 2 trans people has been sexually assaulted in their lifetime. It's, that all leads to PTSD, post-traumatic stress disorder. Layer on top of that there's less access to medical care or no access to medical care because of discrimination within medicine. We have more suicide attempts overall, less access for help with intimate partner violence and other issues, and it goes on. So those are things that affect really all communities that are experiencing discrimination and that are minorities. Some of the stuff that's really specific, and like most of LGBT care is actually not that different from most of the care that I do. I treat depression, I treat anxiety, I treat smoking. I help people work through their trauma. But there is some slightly specific stuff. So some of the specific topics, so things like HIV prevention and treatment, not specific to our community, but much more relevant, certainly for our what is the medical community calls men who have sex with men, which is not entirely inclusive, but that's the term they use. STD prevention. You find me somebody who got good sex ed in high school and I'll give you $1 million. Cancer prevention. So how do the current cancer guidelines apply to our community? What does transition look like? What do the hormones like? What are the surgeries like? What about silicone injections, which is an issue that particularly affects our trans women and trans feminine people. So those are some things that certainly affect our community. And those are some things that we will get into in future lectures. But I think that's most of my LGBTQ 101 talk. We do want to hear from you. What topics do you want to hear about? Do you want to hear about PrEP? Do you want to hear about hormone therapy? Do you want to hear about how to quit smoking? Let me know what you want to talk about. You can put it in the comments, and then we have some secure ways that you can get a hold of us, whether you are currently in the closet and need to be pretty quiet about asking these questions and accessing this information, or whether you're out and loud and proud and dancing in the streets. Please wear a mask if you're dancing in the streets. So I'm going to open it up for questions. We'll see how the tech works.
Rose, for giving us the rundown. It's really, really informative and really helpful. So we do have some questions here. The first one is, how is access to LGBTQ plus health affected by the current pandemic?
Largely in ways that are similar to how it's affected all health. But I think because it's so hard for us to access health in the first place, we are particularly vulnerable. What has happened and what we're all recovering from right now is initially things just shut down. So at my own clinic, we had to stop everything because we had to stop seeing patients in person because we had to figure out how we could see patients in a safe manner that wouldn't then get them infected and wouldn't get us infected. And so that took a little while we figured out also how to do telemedicine, which is now really big, and which we're all still figuring out how to do. And this is not just a Monterey County thing. This is a whole world thing that everyone's wrestling with. Currently, so for a little while at Laurel Family, we were seeing people only by telemedicine. We are now still seeing, we are now back to seeing some patients in person. And I want to guess it's about 50-50 when I'm in clinic right now. On the hospital side, we definitely got a surge of patients where we think we're on our third surge right now, actually, which we only have so many nurses and doctors, so there was a longer waiting period. But those are kind of the core things that I certainly saw as the pandemic hit us. And I actually was just reviewing some presentations from a conference that I virtually attended. And it sounds like the effects of COVID are going to be fairly broad reaching for our community, because it sounds like, at least in some portions of our community, folks stopped taking their PrEP. And so we got a big spike in HIV infections and syphilis infections. So it's going to be a challenge to try to recover from this.
Right. Thank you. So another question, and this is related to, so the question is, how can I find LGBTQ plus friendly doctors in my area? I know that when I was searching, it was just kind of like, oh my gosh, where do I look? Who do I go to, right? And so I was fortunate to find you. But what's the best way to go about that?
Couple of ways. And your audio was breaking up a little bit for me, so just in case it was breaking up for everyone, I'll kind of repeat the core, which is how do you find a doctor who is who can do LGBT care, who has experience, and who isn't going to call you a freak and shove you out the door. So honestly, what I find is a lot of people find their doctors through word of mouth. First and foremost, it's always word of mouth. Locally, we have a couple of resources. sctrans.org is a website that I recommend people check out. I actually helped to maintain it back when I was working with Dr. Hastings, way back in the day. It's more, I think it's being more taken care of by the Diversity Center now, but forgive me if I misspeak. Anyone who's on that list is going to be competent with trans care, and therefore is probably going to be competent with LGBT care. Other places that you can look, there are some places that do provide provider listings of people who say that they do care. So the Gay and Lesbian Medical Association has a list. I should be on it. The World Professional Association for Transgender Health also has a list. You can search for that. You can chat with the Diversity Center folks. And then the other way that often works is just Google. I used to run a blog for a long time, and I kept getting questions of, well, how do I find a doctor? And I would just Google, and I would find the local Diversity Center and say, call them. Chances are young doctors are probably going to be more accepting than others, simply because that's how it tends to skew in general. I will say that a younger doctor is the most likely to have gotten some education on LGBT health in their medical education, but it's still on average only about 4 hours. I don't think I got much more than that at medical school. Love my medical school, but it's such a small sliver of all the things you have to learn. So not to say that older folks don't take excellent care of patients and aren't LGBT competent, but just on a global scale, that is another tip that you can try to use.
Thank you. So another question, I know you spoke about the WPATH earlier. Can you speak a little bit about that?
Yes. WPATH is the World Professional Association for Transgender Health. They are a worldwide organization that actually puts together the standards of care. The standards of care is a large document in many, many, many languages, which is available for free. You can go to WPATH.org and download it if you're curious. But that sets the standard for what is required for hormones and what is required for surgery. So 20 years ago, to get hormones, you had to be in therapy for, I think, a year. You had to be presenting as your gender identity, although they didn't call it that, for a year before you could even get hormones. And then they changed that in the standards of care to be much more sane, where you don't need therapy and you don't need to be presenting as your gender identity. And you could just walk in and say, I want hormones. And if the doctor is okay with that, they just give you hormones. But the standards of care is an important document also for legal reasons, because lawyers will use documents like that to help with their legal cases. So that's WPATH. They do a lot of good work, and they also do a conference every 2 years. So it's one of our big international organizations.
That's awesome. It's awesome to hear that something like that exists. And going off of that question, how can someone begin transitioning medically? Like, where do we start, right?
Fingers crossed your primary care doctor, I'm assuming you have one, is someone who you can talk to about that. There is a misconception that you have to have an endocrinologist. You absolutely do not. There's nothing specialist about anything that I do. So the hard part is finding the doctor. If you are over 18, then again, depends on the doctor. My personal style is, if you come in and tell me, hey, I'm trans, I need hormones, I'll say, okay, let's talk about what kind of hormones, what form, let's make sure your medical history is in line. But I'm not one to question your identity. I work under the informed consent model, that if you understand the risks, then yeah, absolutely, have your hormones. That happens to be my style. If you're under 18, it gets more complicated, because I legally cannot give you a person under the age of 18 hormones without parental consent, unless they are an emancipated minor, which I believe you have to be at least 16 in the state of California. But I am not a lawyer, and I learned that many years ago, and it may have changed. A minor in the state of California can consent to many things. They can consent to mental health care, reproductive care, but this does not fall under that umbrella. So that gets more complicated, and sometimes needs referral to what's called a gender center. So Stanford has one for kids, and that is where I would, if there's something complicated, if we really need the support of a therapist on board to help with the parents, or the family or the school, that is hands down where I would have that family go. But honestly, it just takes asking.
Right. Thank you. So another question is, what is PrEP? And something that comes up a lot is that it's mainly known for gay men to use, which I believe is a misconception. I believe more people use it. But yeah, if you can talk a little bit more about that.
Absolutely. So PrEP is pre-exposure prophylaxis to prevent HIV infection. Anyone who is human and alive is at risk for HIV infection, and I cannot stress that enough. Your risk goes up with certain behaviors, but everyone is at risk. You could be a gold star lesbian who's never touched a man. You're still at risk for HIV infection. All of us are. PrEP is a typically once a day medication that you can take that will drastically reduce your risk of HIV. Back in the battle days, we used to say condoms only, and that's the only way you can prevent it. And then we came up with PrEP, because really condoms make sex feel less good, so people don't want to wear condoms, which makes perfect sense. So for those who are at higher risk of getting HIV, so that's that classic men who have sex with men, gay and bisexual men, anyone who's doing sex work, that is exchanging sex for money or goods or services, trans women or trans feminine people as a whole, and I think that's largely because trans women are more likely to do anal intercourse, which is the riskiest sexual behavior for getting HIV.
Okay, it looks like Rose dropped off.
Okay.
Let's see.
Yeah, and just to talk a little bit about PrEP, Rose is putting together a lot of little PSAs. So we'll be posting different video clips with Rose talking about specific topics like PrEP, like medically transitioning. And this includes like local resources, kind of what Rose was talking about Natividad and the Laurel family practice. But we want to also be able to help folks find resources in wherever location they are. So whether that's Santa Cruz County, San Benito County, and beyond. Rose is pretty knowledgeable about the resources that are in the area. So it isn't exclusively for like Salinas where she works.
Definitely, yeah. In the meantime, I can sort of go over some of the things that the Epicenter provides. Every Wednesday at 7 p.m., we have a social support group called Sharing Circle Online. We do it over Zoom, and that's something that we provide. We wanted to make sure that our LGBTQ plus youth are being taken care of, that if they need access to just someone to talk to or anything like that, that we could create a group that would be able to do that. And so we've been doing that basically ever since April. Like, it took us a couple of weeks to get it together correctly, but since we can't do it in person, we're trying to innovate by trying to do things online however we can. And it looks like Rose is back, so I'm going to go ahead and add her back on. Hey, Queen. Okay, I'm going to drop off.
Hey.
Sorry about that.
Welcome
Wi-Fi
back.
glitch.
No worries.
Perils of living in the mountains. So hopefully
Yeah.
my Wi-Fi is more stable here.
So yes. So while
Awesome.
you were gone, we were just talking about some additional resources.
Perfect.
But is there any other thoughts on like PrEP? I guess one question
All the
that
thoughts.
I have, yeah, one question that I have is, how do we start it? Do we just consult with our doctor about it?
Yep. So let me adjust my mic. Any primary care doctor can prescribe PrEP. There's actually a great website called Please Prep Me, and there are a number of other websites that have lists of doctors who have put themselves on a list saying, I will do PrEP. But really, any primary care doctor can do it. Whether or not they want to do it is a different matter. But yes, it's a matter of asking. Anyone who asks for PrEP by the guidelines should receive PrEP. The only time that you can't do PrEP is if you have HIV. Then you need to be on antiretroviral treatment, which is different. And then maybe if you have kidney issues, like severe kidney issues, like your kidneys, you're about to go on dialysis, that's probably not a good plan. But really, anyone at risk for HIV infection, it's usually a pill once a day. And in the studies, when they looked at how effective PrEP is, no one who was taking the pill every day actually got HIV. That means it was 100% effective at preventing HIV for people who were having unprotected anal sex with HIV positive partners. Like, I cannot stress how important, how valuable, how powerful those data are. So absolutely, I do Truvada, I do Descovy, I will give PrEP, and it should be covered. There's a separate section within Medi-Cal, but if anyone's having trouble affording their PrEP, there are also resources online to help with that.
Awesome. Thank you so much. And yeah, just to reiterate to everyone, we will be posting a video about PrEP specifically that Rose talks about. So that will be available. Let's see. Oh, one big question that I have that, I mean, it's related to like all of our health, right? Including our community. But what are the best ways to protect ourselves right now from COVID? I know that that's like I mean, it's everywhere, right? And we want to stay safe. And I know that there's also like protests going on for, different reasons. And there's just a lot of stuff happening in our world right now. What are some of the best ways to keep ourselves safe, keep our community safe?
Wear a mask. Stay away from people. and really it's a lot of what I think others have also said, but wearing a mask is really important, and it's not about protecting you as much as it's about protecting other people. And if we all protect each other, then we're all protected. There are specific recommendations about exactly what mask you wear. You do not need to wear a medical surgical mask. You don't have to buy the packs of masks and wear masks like what doctors wear. That's actually not the CDC recommendation, and we can debate the whole CDC thing another day. But early in the pandemic, actually, we physicians had issues because we can't wear a cloth mask in our clinic, and we didn't have access to masks because everyone bought them all. So a cloth mask, you can put a filter in it if you want, but wear a mask, not like a running buff, not like a thing, just a cloth mask. Stay at least 6 feet away from people who you do not live with. So it's sort of like your house is your tent or wherever you're living is your living group, and anyone outside of that group, you should do your best to stay at least 6 feet away from them. For a while, actually, you had to wear a mask anytime you were outside if you could not stay away 6 feet plus away from other people. I personally, this is more of a personal recommendation and less of a doctor recommendation. Really think twice about the whole eating in a restaurant thing, because you're exposing, although yes, you're giving the restaurant money, but you're exposing the workers to you when you may have COVID. So get takeout. Don't go. Try not to go to events. Wearing gloves is not necessary. The way it spreads is by droplet and by airborne. So it's the things we cough, the things we spray. If you touch an object that has COVID on it, but then don't touch your face, the chances of you actually getting it is pretty low. It's not going to go through your skin. So you don't need to wear gloves when you grocery shop. Just wash your hands before you touch your face, and don't touch your face, which is the hardest thing in the world, but important. I also want to emphasize right now, please get your flu shot. This is the perfect month to get it. The last thing that anyone needs in the world is to get both COVID and flu at the same time. There's nothing, oh, it's just the flu, about flu. Influenza kills tens of thousands of people in the United States every year. So it's a deadly disease. Please get your vaccine.
Right. Thank you so much, Rose. So those are all the questions that I have. I don't know if any of our team have any questions, or if Rose, you have any questions for us. I know Haley also wanted to share some information.
Hi everyone. I just wanted to share that our PSA videos will be going up soon. They're on topics like PrEP and different other medicine for the LGBT community and beyond that. We're going to be answering questions like how to start PrEP, why you should consider it. Also, we're going to be talking about boundary methods as far as like condoms and vaginal things to put to to have safety. Also other like drug topics as far as like addiction. So that's all coming soon onto YouTube and our Instagram.
Thank you. Yeah, and then we're also going to be posting this video. So it will not only be live, it'll be posted onto YouTube as well. And we're doing our best also to make sure that there are subtitles on there so folks can use that, and then also Spanish translation, and then as many other languages as we can do as well. But yeah, I'm super appreciative of you, Rose. Thank you so much for answering our questions and for sharing your knowledge with us.
Absolutely. It's my pleasure. I have been passionate about providing care for our communities for a long time. I'm really glad that I'm able to come back to California and that I'm able to do this work because I know how important it is. I'm a member of this community too. It's my heart and soul, and I would want to get good care. I want my wife to get good care. I want us all to get good care. So it's deeply personal to me, and I'm just glad I'm here and I can make a difference. Y lo siento por mi mal español. I'm working on it, I promise.
Thank you.
Excellent.
Also, shout out to Alejandra in the comments. I see
Yeah.
you, girl.
Yes.
Thank you for coming, Alejandra. So good. All right. Well, I guess if there's no other questions, we could probably wrap this up.
Yeah.
Absolutely.
Thank you to our viewers for showing up. Please send us your questions, anything that you're curious about, anything that you haven't gotten, like maybe accurate, you feel information on. Let us know. We want to be able to provide that kind of information for you so that you can get it from a trusted source and not from some crazy website on the internet that is telling you blatant lies.
Yeah, thank you.
You can't cure COVID
and,
by bathing in vinegar. Yes.
I was just gonna say we will be posting a survey for everyone to fill out, and this will just help us learn more about what our community looks like, what information is wanted. There's so much information out there, right? And we want to be able to share it with each other. Let's see. Oh, Alejandra says thank you. Thank you.
No, muchas gracias.
Yeah.
Yeah. So
But that's it.
All right. Well, thank you,
let us
everybody.
know what you want to hear.
Thank you for coming. Thank you, Dr. Rose Lavelle. And thank you, Haley. Thank you, Angel. Yeah, that's it. Bye, everybody.
Bye.
Have a great night. Stay safe. Wear a mask.
Absolutely. Drink some water, too.